So I'm here today to talk about data collection within organizations and to hopefully kind of help you walk away with ideas about why having data collected within organizations is really such a good way for us to tell better stories about who we serve, but also will give us the transformative capacity to be able to do work around inequities and be able to track the work that we do. So I'm going to start off with Humans of New York Instagram. I'm not sure if you're all familiar with that, but he's a photographer primarily focusing on telling the stories of people living in New York. And he posts on Facebook, Instagram, and online. And this is a post from back in January. And this is the part that I really want to highlight. So this person is a health economist. And if you read the quote, he says, Monday was Martin Luther King Day, and he said there's no greater injustice in America than our distribution of health care. So researchers can determine your life expectancy based on the closest subway stop to your house. That's not due to genetics, that's not because the breadbasket is running out, that's because of how we choose to divide our resources. And I think it defines our character as a society. And I really like that last line. And when I do a lot of training with staff on collecting, many people will say, but here healthcare is free for everybody. And so I think that really is part of how we define ourselves as a society. But it's often up to me to break the bad news to say, well, you know what? It's actually not looking so good for people who are marginalized here either. And someone back in 2012 had an idea of trying to kind of track life expectancy based on a bus stop. And that was in Winnipeg. And what she found is when you move from the suburbs, the more affluent areas, into the downtown, you'll see that you actually lose a year of your life every few bus stops. In some cases, it's 1 year per bus stop. And you'll see that for males, the differences in expectancy is 14 years. And for females, it's 16 years. And if you pile on the fact that downtown, there's overrepresentation of indigenous peoples, then if you pile on disability and someone identifies as gay or queer, that even means lower health outcomes or worse health outcomes. So so that happens here as well. And that's part of what really drives, at least for me, the passion to do this work. We know there's a lot of data on inequities. It also almost seems counterintuitive that we still need to collect more. But really what we know from a lot of the reports out there is that not all data is created equal, in the sense that the way we collect the data really impacts how we can use it. And, there's a lot of inequities out there, but they tend to, studies on that, but they tend to be pockets of research or collected in ways that are anonymous, that we can't really track anything. And a lot of the reports now coming up saying in order to really tackle inequities, we have to collect data at a very granular level and within our organizations. And so within the LHIN and even a bit beyond, when we first started collecting, we got quotes on what people thought about collecting data. And so Leslie McGregor, who is executive coordinator at the Health Authority, kind of planning urban health of indigenous populations, says they haven't been able to do any effective health planning without data. Karima Karmali at SickKids says that what's really missing is concrete data that gives us evidence about how we at SickKids are doing. Liban at Taibu CHC says, having data for us means we can do more of what is working, I love that quote, and less of what is not working, so we become more efficient. And then this is a bit long, but it's the president of Providence Healthcare. She says, if we understand that people we are serving are not just their health dimensions, so people are not just it's not just about diagnosing a health condition, but we need to see the whole person in the community. And there's been a lot of recognition within the government around these things, and then the LHIN specifically has been very focused on doing something about this. So I'll be brief with this one, but this is just to show that this started way back when a report came out to say this is an evidence-based tool for collecting health equity data, and that's the tool you have in your folders. And then the LHIN kind of stepped in and said, oh, great, this is developed in Toronto, let's use it in Toronto, and mandated its use. And at this year, we're still kind of focusing on expanding it, assessing the data quality, and very recently, and hopefully next year, is really how can we use the data at the LHIN level, but also at the organizational level. And a theme that's really been emerging is we really need to make this evidence-based, data-driven, but also we have to be it's easy to get rigid about how we do things because we invest so much of ourselves in getting started, but we really always have to go back and revisit how we're doing things if it's very obvious that there are better ways. So what do I do? And this is a bit of a nutshell. So because Mount Sinai Hospital had led the development of the questions, the LHIN approached them and said, do you mind helping us implement this across 17 hospitals and now across 17 CHCs? And this is the kind of work that it's taken for us to get this going. And I mean, it looks like a lot, but it's actually me and one half-time person, and then it was me and one other person. So it was really 2 people working across the LHIN on this. So doing staff training that's really focused on making sure people understand what health equity is, communication materials, we do yearly workshops, symposia, we do on-site consultations with organizations, and we have a website, torontohealthequity.ca, that you can visit where everything we've ever developed, we've put on there, and the TC-LHIN has basically said this can be an open for everybody. So it's torontohealthequity.ca. So where did we start? That's kind of our story. We started with 17 hospitals that were quite diverse, so it didn't make sense for us to say, I have an idea, this is how it needs to be done, and that's how everybody needs to do it. That made no sense. We really had to kind of make sure what we recommended reflected where the data was being collected, and then later on the 17 CHCs joined us. CHCs already collected that information, but it was again about going back to not all data is equal, finding ways to make sure that we have standardized methods for collecting the data across CHCs and across hospitals. So this is, I mean, we didn't use this cycle, but I found it online as a way of looking at healthcare work, and I thought it really reflected how we want to do things. So first we plan, then we actually implement, we start reflecting on how we're doing, and we adjust accordingly. So in the planning, that basically meant going out to hospitals, talking to them about what worked, making sure they have inter-collaborative groups to do this work and set up some targets around what you think your missing data should be. What have been some successes? It's really good to see how hospitals come together with each other and within each organization. There's been, and that's really been key for them to share a lot of the knowledge and identify site-specific solutions, and that's what I had been referring to in the beginning. Challenges have been change management, so to say that now an admitting clerk has to start asking these questions was a huge thing. In the case of CHCs, it was, we know you've been collecting, but now we all have to collect in a different way, and that was also challenging. The vision for data use was also an issue because some hospitals just wanted to say, I'm going to collect and report to the LHIN, but others said, we really want to use this. And make sure everybody gets ownership over its use, and then again, agreeing on where to collect and who should be collecting. But those were all solved, and that was really good to see, but it remained a challenge. Then we started actually doing the work, so we built the fields in the system, we trained staff, we collected, starting small, going big, and engaged leadership. So staff training has been the best way to really engage staff, and again, I think staff training and engagement is the key to making or breaking this project. It was easy-ish for us to build it into the system, and then kind of share what people are learning. Some challenges were, you started doing this for a year, now you have other priorities, how you keep it going, how do you do quality checks as you're expanding? It's easy to be like, I'm going to leave this behind and move on, but no, you actually always have to go back and embed it within your everyday operations. Then we started to reflect. So how do we audit data quality? We always made sure the frontline staff gave feedback in many of the hospitals because they're really the experts. And then we continually tried to kind of adapt to workflows in ways to make the data collection meaningful for everyone. And so some successes is having data summaries, revisiting the workflows, and starting small. A huge challenge continues to be pulling the data. I implore you, if you want to take one lesson from today, is always make sure you think about taking the data out almost before you think about building it in, because it turned out to be a lot less direct than we thought it would be. And then finally is you kind of change things as you go along and you share any lessons you have. Connecting hospitals has been great. We've also made changes to workflows and incorporated feedback. So challenges as organizations will always change leadership and how you get them back on board, and maintaining the focus on data quality when there's an equal push to keep expanding. This is a snapshot of what we have in the LHIN out of 130,000 patients. It's just a little t's. And then what do we have in terms of data quality? We see that a lot of them are at around 10% for missing data, which was our target, except for gender. And gender, we strongly believe, is a data reporting issue. So we don't know if it's really the data versus we think there's actually some mix-up between sex and gender fields that we're trying to sort out. But this is really what you want to look at the very end. You want to go back to say, what's my missing data and what's my do not know, prefer not to answer. So how can we use the data? And really, as I said before, it's about creating accountability and transforming care. This is how we've started in our system. We've really tried to push for moving past one size fits all, which is such a big way for medicine to do things, and say, wait a minute, like personalized medicine means understanding who your patients are. That means incorporating patient needs, providing supports, saying I treat everybody the same, recognizing that that's not equity because people have very different needs, and making sure that when we ask, I loved what Marcus said, opening up a space for someone to not to have put the onus on them to disclose. That was a great way for us to kind of say we need to ask. So these are just some notes you can check out later on the slides we got from clinicians on how they've started using the data. So this is another one about a teen patient and how having that information helped him really kind of improve and personalize care. The other thing is, what has it meant for organizations? And it's really meant evidence-based planning. What we mean many things by that. We mean developing patient profiles. I was shocked when I first started to know that hospitals had no idea who they served. And for the first time, now we know, at least until we get to 100% who we're serving. We can identify disparities and determine benchmarks. So if I don't know exactly who I serve and how I'm doing in terms of access, then it's very hard to come back and tell me you need to improve access. Now I have evidence, and now I have benchmarks to do that. That also means getting more money for services we need. And it's been really good for many hospitals to get validation to say, look at my profile. I've been saying for a while I serve very marginalized populations, and now I have the evidence to show it. And ultimately, it's about improving health outcomes. This is, again, I'm trying to give examples here of what they've done at Mount Sinai. So this is by Dr. Samir Sinha, who's a geriatric physician. And he's looking at acute level of care, just how long people are waiting when they're waiting to be discharged and into more care. And so what he's found is speaking English means you wait less. And what's the story behind that? If we just had a database, a research database somewhere telling us this is what we know, then we would have known it's an issue, but it's been very hard to follow up. But here it means we can tell the story of what that means. We can go back to say, why is this happening? I can track exactly who these patients are. We can go talk to them and we can see what we can do about it. And even better, I can go back 3 years from now and say, what does my ALC level look like by language? And that's something we haven't been able to do consistently. And the last piece, kind of more of the LHIN, sustainable healthcare level, is understand who high-cost users are. When we know that around 5% use 60% of resources, our guess is these are very socially complex people. So now we know we can see more about that. We can track individuals across the system. We've never been able to do that in this capacity before. Incorporating equity into reporting structure, and I'm a data nerd, so that's the one I'm really excited about. So now we can say, here's an equity score. Show me your stratification. Show me if you have any inequities. Now we can finally say we need to report inequities, and we can do it only through this data. And then for the LHIN, that means looking at that data, and this is, I should have put quotes, that's a Camille Orridge quote, so we can target, streamline, and deliver programs and services in really meaningful ways. And I mean, ultimately, it really fits also with a lot of the vision, so excellent data for excellent care for all act, that's a typo, and patients first discussion paper, which really focused on equity. So really, it means across the spectrum, we have patient-level transformation, but also system-level transformation. So what are the next steps for us to continue to assess our data quality, to improve reporting mechanisms? That means reporting within a hospital, but also reporting to the LHIN, submitting the data to, for example, ISIS, and the LHIN's really committed to that and working on it, and that's really exciting. Stratifying our health outcomes, so again, that's something we've never properly done before, and then we really want to continue to expand the data collection in ways that respects the integrity of the data, otherwise all this work would have been for nothing. So, if I had a time machine and I could say, okay, if I knew then what I know now, what would I have done differently, or what can I pass on to other people? I think really going back to the anxiety really comes from the staff way more than it comes from the patient. We've had 130,000 patients, you can see, and we've had 5 or 6 complaints. That's less than 0.05%. And continuously, the struggle continues to be staff saying, it's none of my business, I don't want to ask, this is taking too much time, and not at all from patients saying, I don't want to respond. So if I could go back, I'd not make the focus the patients. I mean, we have to keep that in mind because it's about them, but I'd increase the focus on staff anxiety and say, we need to revisit why you're so anxious about this. I would set targets around collecting in high volume areas. So instead of saying to yourself, oh, I'm going to collect from 60% of who I serve, that can be very difficult to calculate. I would say, you know where your high target areas are. You can start small, but within a year, I want for example, your 3 most busy areas collecting the data. I think that's a more kind of solid way of having targets to meet. Include data reporting piece from the start, but what I mean by that is the IT. Making sure that on the table you have people who are building the system and people who really understand how you want to pull it, and those people who work in reporting are very different. So having them involved, do not expect that if you're already collecting, that'd be very easy to just substitute these forms into your old forms. We saw a lot of resistance, partly because people felt like they were very attached to what they'd collected before, partly because we're really asking them to standardize in ways they weren't used to before. And so we found that equally challenging as starting from zero. And that was a big lesson for us. And then anticipate that people don't have the same understanding of health equity. Perfect. I'm actually on time, but I do talk fast. So just when we went out, as I said, everybody used to say, I don't discriminate. I treat everybody the same. I'm here to help people. And sometimes it's not discrimination. Sometimes it's something else. And just making sure that treating everybody the same, I can't say it enough, is not equity. It's actually inequitable. It's equal, but equal is very different from equitable. And so what we go back to say is, your patients are very different. Do you want to be treated like another patient exactly the same? Of course not. Everybody wants to be met at where they're ready, what their readiness is, what their information is. And so that's really making sure we go back to say health equity is about equitable outcomes, not about equal treatment. And the other thing is, sometimes it gets really hard to keep going. It requires a lot of resilience. And I once saw a speaker who said the moment you're sick of talking about health equity is the moment everybody starts to listen. And that's always good to keep in mind because it's such a long game.